This video will demonstrate the far lateral craniotomy and transpontomedullary sulcus approach for supraolivary pontine cavernous malformation resection. The patient was in her late 30s. She presented with double vision, dizziness, and tinnitus, as well as left hemibody weakness and numbness due to an earlier hemorrhage 6 weeks before. On neurological examination, she had left hemibody tingling intermittently and a mild right facial nerve 6 palsy. Here are her MR images in axial, coronal, and sagittal views showing the lesion in the supraolivary portion of the pons. Notice on the sagittal view to the right how the malformation lies in the underbelly of the pons right at the pontomedullary sulcus. This was the site where the lesion came to the surface and will be our entry site. This MRI shows the associated developmental venous anomaly. Her brainstem cavernous malformation grade was a 4, with points assigned for size, crossing the axial midpoint, presence of a developmental venous anomaly, and subacute hemorrhage. These illustrations show the positioning and exposure of the far lateral craniotomy. Strategy consisted of the park bench position with the head flexed, rotated, and angled towards the floor, the far lateral craniotomy with C1 laminectomy and occipital condylectomy, opening of the cisterna magna and tonsillomedullary fissure, following of the caudal loop of pica proximally, entrance into the vagoaccessory triangle and identification of the pontomedullary sulcus, localization of the hemosiderin stain, entrance into the pontomedullary sulcus, then circumferential dissection of the malformation, and piecemeal resection. Here's an overview of the surgical exposure. The top of the head is at the bottom of the screen, feet are at the top, and the condyle is up to the upper left. Here, the caudal loop of pica is seen underneath the inferior edge of the tonsil. Pica becomes a landmark to follow more proximally. Here are the rootlets of the 10th nerve en route to the jugular foramen. Here, the inferior medullary velum is being incised in order to more aggressively mobilize the tonsil upward. Now you can see the 10th nerve with the 9th nerve heading into the jugular foramen with the 11th nerve. Choroid plexus sits right on top of the 9th nerve, and dissection into the GCT or glossopharyngeocochlear triangle gets to the ventral surface of the pons. Here you can see the underbelly of the pons. It has a bright white appearance, and the location of the hemosiderin stain is more medially. Here is the pontomedullary sulcus, and you can appreciate just a faint hemosiderin stain. The sulcus is incised, and with spreading dissection, the associated hemorrhage cavity is reached. You can see the chocolate brown fluid around the malformation, which is evacuated. As I enter into this cavity, you can begin to appreciate some old clot, subacute clot, as well as some fresh blood and also the malformation itself. Here is a piece of the malformation being removed. By removing some of this clot and malformation tissue, the cavity opens up, creating some working room within the cavity. By using these angled round knives, I'm able to break up the adhesions between the malformation and the surrounding pons. The malformation is removed piecemeal. Here is a nice chunk coming out as a specimen. It has the classic mulberry appearance. I continued more deeply, and additional malformation is seen here. The malformation continued to extend more cranially. The trajectory is providing an upward look into the central pons, and I'm chasing down this tissue, which is disguising some underlying cavernous malformation tissue. As this is better exposed, it is removed piecemeal. The round knives nicely help separate the malformation capsule from the adjacent pons. You can see a little portion of mulberry here with that classic purple appearance. And then the malformation, once freed, can be lifted out and resected. I'm exploring the upper pockets of the cavity to make sure there aren't any remnants left behind, and we're beginning to see this normal appearing gliotic wall around the cavity. Here's the view once all the malformation is resected. You can appreciate the clean color of the wall. Here now is a view into the vagoaccessory triangle that brings us to the basilar trunk. The basilar trunk is seen running along the clivus in front of the pons. Here's the 9th and 10th nerve bundles running together. This bundle forms the top of the vagoaccessory triangle. And here now is our final overview shot. This case was a nice example of the supraolivary pontine cavernoma. These patients can present with a 6th nerve palsy, which is isolated, or they can present with a Millard-Gubler syndrome with the 6th nerve palsy, 7th nerve palsy, both ipsilateral, and a contralateral hemiparesis or hemiplegia. The wiring diagrams for the tracts are shown in the illustration to the left. The surgeon's view is shown to the right. You can see the exposure of the far lateral approach and the entrance into the malformation through that underbelly of the pons and through the pontomedullary sulcus. The patient tolerated the procedure well. Her right 6th nerve palsy was exacerbated. She had a slight facial droop, which resolved, and she had some mild swallowing difficulties and left upper extremity weakness, which also are resolving. Here you can see the sequence of the MRIs are shown in running axial, coronal, and sagittal views. Her postoperative MRI demonstrates no residual cavernous malformation. In conclusion, supraolivary pontine cavernomas present with ipsilateral abducens nerve palsy with or without associated facial and contralateral hemibody weakness. The far lateral craniotomy and transpontomedullary sulcus approach through the vagoaccessory triangle is the preferred approach to supraolivary pontine cavernous malformations. The trajectory through the vagoaccessory triangle and over the olive accesses the pontine underbelly and central pons for complete lesionectomy, even when the lesion is surrounded by normal tissue. Thank you.